Good afternoon and welcome to the second in our Thematic Innovation Ecosystems on mental health. Today we're targeting the topic around adolescent mental health, and in particular, where are the needs and the best practices around adolescent mental health across our global network of ecosystems. We're here today, I'm brought together by colleagues from our Rhineland-Bonn ecosystem and our Norwegian health tech ecosystem. I'm going to gradually talk you through what we're doing today. Just onto our next slide, please. Obviously, you know this session's being recorded. If you do not wish to be filmed, please get rid of your microphone, turn your microphone off, and untick your camera. Just so you can see what we're doing today, there's the agenda in front of you. Can we just go back a slide, please? Got a packed agenda today, so I'm going to be as brief as I can with my intro today. And we've got excellence coming from our Northern Ireland, Norwegian, Scotland and Highland Islands ecosystem, as well as from within Germany as well. And I think great input. So let's crack on. Next slide, please. And so just about who I am. My name's Andy Bleeden. We're going to the next slide. That's the other way, lovely. On to our next slide again and again. I work for the European Connected Health Alliance. We're a member organisation.
The objective of this reform is to ensure that everyone has equal access to our healthcare services. And on the other hand, the aim is to ensure that people have smooth access to health and social services and they can receive help for their individual needs. And this reform is this reform will transfer the responsibility for organizing services to 22 health and social services. And one of these will be the Northern Ostrobothnia Health and Social Service County. And currently this is this hospital district, but the name will change. And this is part of a bigger program, Future Health and Social Services Centers Program, Finland. And this POPSOTE project where I work is a part of this bigger program, and this innovation and testing activities sub-project is also part of this bigger program. And this sub-project aims to develop and implement local co-creation model to enhance different stakeholders, for example, citizens, participants, citizens, healthcare professionals, companies, and researchers' participation in development of health and social services. And what we have done, we had a survey of development needs, and we aimed to get input for local co-creation. We conducted 3 separate surveys, and they were targeted to mental health services, children's, adolescents and family services, and services for aging population. And response time was about 3 weeks, and those surveys were distributed in social media and so on. And the purpose was to gather development needs and wishes related to the arrangement of these services by open-ended questions. And we aimed also to conduct approachable, simple surveys, so we didn't collect any specific personal details. And the target population was professionals working in our social and health services and citizens. And we get 840 responses to these 3 services, and we analyzed those by thematic grouping, and also we recognized few clear research topics. And now I'm presenting those adolescents' mental health related results, and we recognized 3 different development needs themes. And those were the need to develop digitalized solutions, for example, self-help tools, digital care and services paths, supportive therapeutic interventions and digitalized ways to conduct services. For example, chat services were presented as a need. There was also a need to develop preventive mental health services. And for example, preventive substance use education for adolescents, exercise counseling and nutrition education for adolescents, updating education for different healthcare professionals who meet these adolescents in their work to strengthen their competence. And these professionals like public health nurses or school nurses. And also solutions to decrease adolescents' loneliness were highlighted. There was also need to develop access to care and availability of care through different kinds of flow entry services. And equality of care was also pointed out, and there was also presentations, suggestions about psychiatric school nurse model. So the needs were quite big, and there was also some specific, but quite many of those were quite overall, and we think that the grouping was good way to recognize those which can be utilized in future. And what we are going to do in future, we hope that we can utilize our model for co-creation, and we are going to create some innovation challenges to innovate solutions for those bigger development needs, to gather more specific ideas. And we hope that we can involve different stakeholders to this process. And on the other hand, we are going to benchmark existing solutions for more specific development needs, because there was quite specific digital needs. And I think that there is some kind of solutions already. And we hope that we have a lot of new ideas and innovations that we can co-create and test it with actual end users and stakeholders to enhance customer orientation and to respond to the objectives of national reform. And I think that this was shortly presentation, and if you have any questions.
Thank you for that, Jenny. It's very, very informative, and I think a really good example from Oulu of how to establish what needs are there and use co-creation as a tool with young people. So that's very, very helpful, and I think something that can be maybe adopted in some of our other ecosystems too. So it's very, very helpful. We've had a long-term relationship with Oulu as one of our first non-UK ecosystems. So it's really great to see you representing Oulu, and in particular your organisation from Finland. So thank you very much for your time, and we'll come back to you later as part of the panel discussion too.
Yes.
Okay, thank you very much for that. Next up, we're not going to go very far. We're going to go just into Norway and hear from Morten. Morten,
hello.
Please. Hi, thank you for that. The floor is yours.
Thank you for the invitation and introduction, Andy. You can go to the next slide, please. My name is Morten Ørbekk. I'm the head of the Department of Children's and Adolescent Mental Health here at Oslo University Hospital. It's been a quite hectic year for us since last fall. Next slide, please. So what have we experienced? Well, we have seen a major increase in referrals regarding eating disorders, depression and anxiety. And that is also a tendency when you read the European reviews regarding the pandemic period. We also see that the patients with more severe conditions are getting younger. We have a big concern regarding young females with severe anorexia, who is down in 10 years old that from 10 to 12 years old has been the most major increase. So that is a very big concern. We've seen an increase in demand of flexibility in the services. So we have to address the home hospital infrastructure because we have to solve the isolation problems. And this tendency is consistent with the feedback from the community user organizations, which also, as we speak, have a big concern regarding enough people to address the demand. We've also seen challenges in recruiting qualified clinicians, especially psychologists and doctors. And that is one of my big concerns today, because we now have some positive initiatives from the government regarding resources, but we have hard getting the qualified clinicians. And part of that is explained in the workload, reported workload, and that's a big concern. And for me, who has seen this this development the last year, I was out in media in September of 2020 and had a prospective assessment of the development, especially regarding the patients with anorexia. And I have to say that there's been a lack of proactive political response to that concern. The focus in the hospital here in Norway has been regarding the somatic patients and not a structural plan regarding the mental health patients. So it's been better the last couple of months now, but still concerned around the systematic approach and resources aligned to that problem. Next slide, please. So the media has contacted us the last year regarding the causality and how do we understand this. And I've earlier made a descriptive approach to this regarding the increasing referrals, both for outpatient clinics and our inpatient clinics. And the increase has been around 40% to 50%, so it's quite radical. The protective factors from the reviews regarding the European hospitals is the routine and the lack of routine. That is a risk factor, but also a protective factor. We've also seen the family communication as a protective factors, and the social support and the play and leisure. So when the isolation goes up and the resilience factors around in the community is downscaled, that is a big problem. And we've seen difference between Norway and Sweden, for example, where Sweden have had open schools, but Norway has closed it, and that is one of our hypotheses regarding some of the more severe anorexia patients. Other risk factors have been gender and female gender. Adolescence age is a risk factor. The previous mental health problems. So we have escalated on a previous mental health problems during this period. Also, the media exposure around COVID has been a challenge. Also, the social media, which increases when the isolation increases. And also when relatives are doing first-line job related to COVID. That is, we've had clinicians and parents in our hospital who has had several hundred hours of overlay, and that also connected with how much they can be at home following up their children. And it's also a ratio connected with the community case frequency. So that is the review in Europe. Next slide, please. So where do we go from here? We talk about that the pandemic has changed the way we have to work. I have to assess this in another way. I think we have to develop our services not because of the pandemic experience, but because of the future needs and demands from our patients. And that is work we have done before the pandemic. So we have to do it because of that. We also see a new infrastructure that must be integrated in the existing workflow for clinicians and other personnel. A new solution must be integrated into conventional services as a complementary service. Everything cannot be solved with the digitalizations and home hospital. And also we have the case of centralization, which I think is inevitable, because the best soccer players go to the best soccer teams, and we see that our clinicians cluster up and we get centralization, and that is a challenge. So I talk often about the counter centralization lies in the use of technology to democratize the services, especially regarding the specialist consulting, and I come back to that in the next slide. Next slide, please. Okay, so the flexibility in the services, the home hospital concepts we've been working on for several years, also the virtual hospital discussion. We have over a couple of years now made real-time holographic solutions, which can project real-time holograms to the patient and integrate that in clinical protocols, which also can be used across countries and in our country. So if I need, if my services are needed in Trondheim or north in Norway, we can project the real-time hologram and consult patients, other clinicians, and also parents. And so we are soon finalizing that project. So it's very exciting. Also, we have to discuss the generic versus the innovative, because I think we are too far in the cost benefit aspect, duplicating our services. So we have to be better on differentiating our services. And that challenge is also regarding to the future economical limitations. Next, please. Yeah, thank you for listening.
Thank you for that, Morten. I think you've picked up on a number of topics there that I think a lot of people will resonate with, especially around media. I think since the pandemic started, I've been hearing media saying there's a pandemic tsunami coming, and heard it every week since. I'm starting to think that may also make a contribution. So thank you very much for that.
Thank you.
We're now going to, and we'll come back to some questions, I hope, later on. I'd love to introduce now Professor Carla Verlinden, also on this topic, but specifically around youth resilience and the concept of leaving no one behind. Carla, please, if you could unmute yourself, and I'll mute myself.
Yeah, thank you for having me. Morten has now said a lot that I can confirm, and I hope I won't bore you now, but let's see, maybe there's something new in it. Okay, resilience. My name is Carla Verlinden. I'm a professor in Germany at the Catholic University in Cologne, Germany, in the western part, and I'm also a psychotherapist for children and adolescents. Today, I would like to tell you something about the connection between resilience and the COVID pandemic. Before we look at how resilience has evolved in pandemic times, let's take a brief look at what's behind the concept of resilience. Next slide. Okay, resilience as a counter construct to vulnerability is a transactional, lifelong process of adaptation and learning, characterized by the ability to successfully adapt in the face of challenging and highly stressful circumstances in terms of inner well-being and/or effective exchange relations with the environment. As Marsten observed, thanks. Marston observed 2 decades ago. Resilience does not come from rare or special qualities, but from the everyday magic of the ordinary, normative human resources in children and their families and relationships and in their communities. This ordinary magic in children, families, and communities has a crucial role in the scientific and public health response to COVID-19. Next slide. This ordinary magic, as Marston says, is what we call protective factors, which allow young people to respond resilient to adverse circumstances. These protective factors contrast with risk factors and change over time. They can be strengthened, but also weakened. What are important protective factors? Let's see. You have to click twice, and next time, here we go. The most relevant protective factors are self-efficacy, feeling of coherence, social competence, grit and persistence, feeling socially connected, and secure attachment to caregivers. The most relevant risk factors are negative emotions and dysfunctional emotional regulation, lack of problem-solving strategies, chronic family disharmony, and social isolation. Of course, there are much more. It is easy to envision how COVID-19 has been, or still is, the impetus for a host of lingering negative outcomes. Schools were closed, adolescents had remote learning and suffered from stay-at-home orders. This leads to unpredictability in daily routine disruptions. Adolescents recognized political disinterest. The attention regarding COVID diseases in children and adolescents came very late. And the young people have seen that millions of euros were spent to save airlines and hardly anything was spent to save young people. In Germany, we do not have air filters in schools yet. And we are one of the most richest lands in this country, in this world, so it's a shame. Due to social distancing, there was little peer contact in face-to-face settings. This often felt like social isolation. This was accompanied by a reduction of leisure activities and opportunities to experience self-efficacy. Parents and caregivers simultaneously navigate parenting, financial and professional challenges and uncertainties. And in a special way, children and adolescents depend on the resilience of families, school system, politics, and peers. Because families, peers, schools, and communities have a role in nurturing the growth, stability, and recovery of these systems. And while the resilience of entire communities was activated during the pandemic, like solidarity for at-risk groups, or helping each other out, shopping for each other, preparing meals and everything, adolescents were and continue to be at the mercy of adverse circumstances where building protective factors is more difficult. This is particularly evident among marginalized people. Next slide, please. How has the situation of young people challenged in the pandemic? Internalizing and externalizing psychopathology increased substantially during the pandemic. Anxiety disorder, depression, self-injury behavior. Children and adolescents reported more frequent psychosomatic complaints such as irritability, problems falling asleep, and headaches. And this has led to higher demand for psychotherapy for adolescents in Germany. We have physical effects. Due to the lack of exercise, we are seeing an increase in obesity and, interestingly, an increase of anorexia, like Morten said. Preliminary studies have already been conducted that identified protective factors that moderate adolescents' mental well-being during the pandemic. I would like to briefly present these to you. Next slide. Comparative studies show that those adolescents who possessed the following protective factors to a high degree came through the pandemic without any mental health problems. Passive screen time. Passive screen time can be identified as a protective factor. Early in the pandemic, youth who spent less time on digital devices each day had lower externalizing symptoms, controlling for pre-pandemic symptoms. Consuming less than 2 hours news per day was also associated with reduced externalizing symptoms early in the pandemic. Youth with more structured daily routine had lower externalizing problems 6 months later. Sense of belonging. and having access to resources like hobbies and assets like tutors, own rooms, possibilities of retreat were coming through the pandemic with less mental health problems. Right, next slide. Conclusion. Several implications arise from the findings above. Overall, adolescent public policy should focus on decreasing inequalities in access to resources among adolescents from different socioeconomic strata. Overall, policies and interventions would likely be beneficial if they help young people maintain a daily structure and daily routines, if they provide adolescents with opportunities for social rewards and a sense of belonging, as well as if they provide access for youth to resource from which youth can get support. Because sense of belonging is a significant psychological resource, especially in times of stress. And feeling socially connected during the pandemic has been found to associate with lower anxiety, depression, and higher life satisfaction during the current pandemic. Adolescents need validation that what they are experiencing is indeed a disaster with vastly negative consequences, but they also need opportunities to offer support and help, because such opportunities will help them build a sense of agency and self-efficacy. Health promotion, prevention, and early intervention strategies need to be implemented to support adolescents in coping with COVID-19 pandemic and to protect and maintain their well-being, quality of life, and mental health. If we don't take care of the needs of young people now and develop their protective factors, a very vulnerable generation will grow up, the consequences of which we cannot foresee for society as a whole. It is absolutely worthwhile to invest money now in this generation and its resilience. Thank you for your attention.
There you go. I'm going to hand over now. Thank you very much for that. That was fascinating. I think, and my background's in psychiatry as well. I should have said that right at the beginning, but fascinating always to see the psychological aspect too. And I think that could be a universal picture you painted there. So thank you very much for that, and very informative. Okay, I'm going to hand over to my colleague Alexia,
who has no degree in psychiatry or or the like. And I was all the most fascinated by the three keynotes. Thank you very much to all three of you, highlighting different facets of the needs of adolescents in their mental health behaviors, or the behaviors and the mental health implications of COVID in particular. So thank you very much. The next session will be highlighting now, after we had the understanding. You gave us the basis to understand what happened. You gave us the numbers, and now we will look at some of the solutions that might not have emerged directly out of COVID, but might have been designed or co-created during COVID, or have nothing to do with COVID but address adolescent mental health in particular, and which is why they fit in here. And I'm thrilled to have 4 speakers. We will keep it short since it's very much solution oriented. And I will do it in the order you are listed here. So I will start with Mark. Mark, thank you so much for joining. We really do appreciate it. You took part to the first mental health gathering already. You come from the University of Highlands and Islands in Scotland, and you are a senior lecturer and researcher in digital health over there, and you do work with young people and very closely in designing solutions that they say they need and they design, and I'm very excited to hear all about that.
Okay, thank you very much, Lexa. It's really interesting, and thanks to the keynote speakers there, that there are certain strands that are running through and emerging here that I don't think we can ignore, and I'll come to that in due course, mainly around the issue about and the need for co-design, and that actually when we think about solutions, we're not just looking at products, we're looking at processes as well at the same time. And I think I think that's a good place to arrive at, and that's what I'd like to argue. So just by way of brief background, my background's not in health, it's in film, television and computer games as a screenwriter and producer, and I became interested in how we can use interactive audiovisual entertainment to engage young people in mental health improvement interventions. And it's been the model's been used now in numerous interventions, both adolescents and adults. But it brings us to a place, as I say, where we can really start now to link up what policymakers are saying is needed, what the research is saying that's needed, and actually what the young people themselves want and desire, because it does often get left out. I'm just going to go to my, so really just by way of context, my research again is in digital mental health, mainly with adolescents. And the context of that is very much the Scottish Government's mental health strategy 2017-2027, which again takes an early intervention and preventative approach. They argue that every child and young person has appropriate access to emotional and wellbeing support in school. We would argue socially and at home as well. And that we have evidence-based interventions to address behavioural and emotional issues in children and young people. And we're particularly interested in how that works in remote and rural locations internationally. So we know there's a need, we know there's a problem, that's not a doubt. You only need to pick up the paper every day and you know, talk of this tsunami of mental health issues that we're likely to encounter over the next 2 to 3 years, and that we need to be ready for it. A lot of the research argues for metrics, you know, the use of population surveys, use of Warwick, Edinburgh mental well-being scales, etc. And the results can be put in context, that we know that the substantial research has been done, but that we also need to take cognizance of where the gaps are, in that there is very little research that has been done through the process of engaging young people in the co-creation of interventions by and for people like themselves. And that's really the sort of front that we've been pushing on. I'm not going to go on too long now, but I'm just going to mention 2 projects. The first is a project we're working on with Highland Children's and Young People's Forum, and funded by the Alliance, and includes day one mentoring. And we were funded to come up with a digital tool to help young people self-manage their conditions over time. But rather than saying, okay, you know, here's a technology, you know, let's develop it and show it them and see how it works, we started with them and asked them what they needed and what they wanted and what they already used. What came back from those development workshops with those young people was, they wanted to belong. So this already starts talking, you know, to the previous presenters' work, a clear sense of belonging. They wanted to feel safe, not just in terms of the digital safety, but in terms of the environments were properly moderated. And they wanted peer-to-peer to support so they could help people like themselves. And I think that's a really important thing to come out of this, is that they don't just necessarily want to be helped by adults. They want to be able to support each other. So what emerged was from these conversations with young people was that there were 3 needs they wanted. One was the peer-to-peer support. The other was that they felt they wanted to be in control of their mentorship process and their self-management process, and they wanted to be able to actually choose who their mentors would be. And the third that came out of it is that they were very excited about the use of VR, and we worked with them with VR technology, and it quickly transpired that, you know, they were ready to embrace that. So what we did was we built firstly the Mentor Matcher app to allow them to choose their mentors, all accredited, and to schedule time to meet with them virtually. we use the Discord platform, which some of you may or may not know. It's actually started being used in the game sector, so it is already young people friendly. But that enabled them to identify with people like themselves, with conditions like themselves, and to help support and be supported by people like themselves. And then the third part we tested with them was the use of virtual reality. We used big screen. And again, what we found, because they were able to get involved in activities within that space, exploring Mars, exploring woodland locations, even sort of cityscapes, that they again felt in control of the process and not inhibited by it. And they felt much more comfortable talking with the mentor as an avatar, because the pressure to talk was gone away, but that environment and those activities allowed them to feel comfortable in that space. So that's where we're at now. That platform again is going into another iteration, and will hopefully be rolled out and scaled up. I'll quickly mention another project.
Mark, I'm afraid we'll have to move the other project to the discussion.
Good. No, we don't need to. Really,
no, I'd love to, because I know that we chatted about it before. I'll leave the floor to Martin, and we'll come back to it in the discussion if that's okay.
That's fine.
All right. So we now have Martin Rademacher, also based in Germany, but at the other end, how it feels. So slightly more southern than Cologne. Martin, you used to work at a software company, and you decided to found Bodaboo 2 years ago to bring mindfulness closer to children. So let us hear all about it. I also received your presentation. I will start sharing it now. Welcome, and the floor is yours.
Hello, and thank you for having me. I'm glad I can be here. I'm happy to share what we did the last two and a half years. You can go to the next slide, please. My name is Martin. I founded Bodaboo in 2019. I co-authored a children's book, which named Boo and the Magic Mist last year, which is a mindfulness meditation book for young children. Next slide. Maybe to start up, I would like to shortly explain you what is Bodaboo. We tried to create an easy to use, child-friendly, a little playful app for children to get them into the topic of mindfulness and meditation. The basis of the app is a mindfulness course, which is loosely based on MBSR for children. There are a lot of meditations inside the app. There's a big library of different things where we can scroll through and find things they just need in this current situations. And beside the meditations, there are sleep stories, guided journeys. There's a little small part with yoga for children. So everything children can use to get into the topic of mindfulness, and which should help them to calm down, relax, and which is very important, especially in this current times. Next slide. We developed the app together with teachers and mindfulness experts for children. So all the content of the app is based on a long range of experience from different persons. As I said already, the course curriculum by itself, it's roughly based on MBSR for children. So it's an 8 weeks course, and we cover all the topics which is inside the MBSR course as well. But it's all things are made very child friendly. But we're not a medical product yet. We would like to be licensed in some kind of way, but we don't have the resources. So we just a child app that should help them in some situations. Yeah. I would quickly talk about the learnings out of the last 2.5 years. We got the app online in the summer of 2019, as I said. We started to reach with a vision to reach the age group from 6 to 14 with our course and with our app. And we already thought from the very beginning that it would be very important to have the content tailored to different age groups, which was a right thing we thought about, because as we see now, our course is used basically by children between 8, 9, 10, maybe 11, 12 years max. So we have a smaller range we can reach with the course right now, but we have a very huge number of even much younger children which are inside the app, which are very curious, they just try out things, and they are heavy users of things like sleep stories and things like this. So we have really users which each evening use the app to get to bed, calm down, and get relaxed. And this is also the time that most of our users really are using the app, which is also a little a sign for us that the parents are using the app for getting the children to sleep in the evening. So they just need a tool to help them to get rid of the stress, calm down at the end of the day, and get to sleep a little better. And we experienced a huge demand since COVID-19. So it started beginning of last year. We saw a huge increase on downloads and user traffic, and which is a strong sign for us that something like this is really needed in the current times. Yeah. Of course, we are still in the beginning. We are still a startup. We have some visions, and we would like to reach more and more children. The app right now is only available in German language, so we also tend to have English content at least to reach children worldwide, because we all have the same problems all over the world. We would like to validate our approach with the app with some kind of studies. We did some first steps, but when there was COVID-19 and there was other things needed to be done. And of course, we would like to reach different age groups. As I said, right now we have 8 to 12 is our main group. We are a little younger as well. I think there is a very important age group, 12 to 13, 14. They have big problems, and they might need something like this as well. So there are some ideas which we will go for in the future. Yeah, that's it. Thanks for having me. If you would like to have a look into the app, it's available for Apple and Google. Download it, and if you need some more conversation, if you would like to contact me, just get in touch. Thanks.
Well, thank you very much, Martin. And I have to admit, so you were brought along by my colleague, Catherine, who contacted you, reached out. I haven't downloaded it yet, but I will for sure. It's great to see what you've been doing so far. I'll hand over to Jenny again, because you also actually, out of the research that you conducted and that you presented before, you came up with a solution, and we would of course like to hear that. So
yes, you can share the presentation now if you
sure
can. I haven't changed that anymore. As mentioned, I'm also a postdoctoral researcher in University of Oulu and belonging in our health coach research group. And as I haven't told that I'm also a psychiatric nurse, I have worked 10 years in the field of psychiatric nursing with children, adolescents, and adults. So I have many interfaces to this topic, and now I'm currently trying to start my research, which investigates modified solution, which is a treatment for depression. Next slide, please. And let's get that. And about the solution, it is mobile platform for mental health patients, and it also includes cloud-based tool for healthcare professionals. And this solution aims to ensure the continuous care path with real-time monitoring. And as this picture presents, you can see that patient can screen his or her mental well-being and evaluate digital mood diary and add her or his mood daily. And there is also included clinical questionnaires, which are used, for example, when asking about depression symptoms or substance abuse. And what this cloud-based tool for healthcare professionals do, healthcare professional can see how the mood of the patient develops. Is there any bad days or good days, and see how this professional can help better this patient. And this solution is a medical device, and it's developed in cooperation with Oulu Health Ecosystem. 2 years ago, this has been launched, this application. And next, please. And currently, I'm investigating how this application works. And my research includes quantitative and qualitative approach. And I tried to describe how the usability, feasibility, and acceptability of solution is, and how the solution affects on the relationships of quality of patient care relationship. And on the other hand, we are trying to investigate the operational reliability of the solutions. And by interview, I try to describe end users' actual experiences on the solution. And target population is 18 years old and older young adults who have symptoms of mild or moderate depression, and they should have to have active patient care relationship, because patient can use this application individually, and the application gives some feedback, but it can be also connected that healthcare professionals can see those patients' notes and daily marks. But this requires that the healthcare organization has license to use this. And the aim of this study is that the patient is using this application, and there is healthcare organization and healthcare professionals who have license to see those patients' information, so we can evaluate how this influence on the quality of care. There is upcoming publication about this. We have wrote a letter to editor article, and we described this co-creation process and how this application has been developed this far. And we hope that we can in future continue towards adolescents and young adults and investigate more closely how they are evaluating this application. Thank you.
Oh, thank you very much, Jenny. Yes, the publication you mentioned will be in English?
Yes, it will be in English.
That's great, because I get there's a lot of interest at the moment around co-creation methods, and since you are describing how to get, basically you are suggesting that framework for the development of further solutions. That's I guess that's going to be really interesting for a great number of people. Now, last but not least, we've got Fanine. Fanine Bradley, thank you very much for joining and for being patient. And thank you to everyone for sticking to their time, because it means, Fanine, that you do have the same 5 minutes as everyone else had. And your background is in business, and you have been now managing the Career Academy, if I'm not wrong. So obviously working very closely with students and their thoughts about their future, and I guess you have a close understanding of how they get on about how they think about their lives and what they're most afraid of, and we're very much looking forward to hearing more about that. So the floor is yours. Thank you, Fanine.
Thank you very much, Alexia. As Alexia said, my name is Fanine Bradley, and I'm the Careers Academy Manager and Deputy Head of Learner Services at Northwest Regional College, based here in Northern Ireland.
So sorry, you did send your presentation, didn't you?
I did. I can share if you haven't got it. Yes.
Well, it's not in the version of the document I have here, unless it's one slide. It's one slide further down. Let me check.
Let's let Fanine share perhaps.
Yeah, I guess that will be easier. Sorry about that, Fanine. I thought you.
I'll just try and share here now. Just 2 seconds. Just let me know.
We can see the screen. It's appearing. It's not full screen yet. It is now.
Go.
Thank you.
Okay, so I've just introduced myself, so I just want to give you a background to what I'm going to talk about. I'm talking from an education perspective and my role within student services. So today I'll just give a brief introduction into Northwest Regional College, touch on adolescent mental health. I'll talk about our partnership with Elemental Social Prescribing digital platform. I'll touch on the impact, and then there's an opportunity for any questions. So about Northwest Regional College, we are the main provider of professional and technical education, including further education and higher education from levels 1, entry levels, level 1, right up to level 6. Based in the Northwest region of Northern Ireland, we have 3 main campuses with sub-campuses below. So we have our main campus in Derry, Londonderry, and we have also our Springtown campus. We have a further 2 campuses at Limavady, including Greystone, and we also have a campus at Strabane. Now, Northwest Regional College operates across 2 district councils, namely Derry City and Strabane District Council and the Causeway Coast and Glens Council. So a bit of background about the nature of the students that we are working with. So Northwest Regional College has the highest number of enrolments across the sector of students residing in areas that are indicative of deprivation quintiles 1 and 2, meaning they have the most deprivation measures. These students can therefore require additional support and guidance throughout their time at the college. And our student services team provide a team around the student support intervention service. And that's made up from a team of safeguarding, careers, learning support, widening access, student finance, students union, and students' wellbeing. But the common purpose is to improve the success of the student. So obviously in terms of adolescent mental health, internally within Northwest Regional College, the mental health, anxiety and depression has been growing within the college over recent years. And in Northern Ireland, the Youth Wellbeing Survey was also commissioned by the Health and Social Care Transformation Funding and was compiled by our local universities and our Mental Health Foundation. And it did recognise that 12.6% of children and young people in Northern Ireland experience common mood disorders such as anxiety and depression. Now, this is obviously 25% higher than other UK nations. And then internally within Northwest Regional College, internally within Northwest Regional College, we have the same area of concerns. If you can see here, this is a snapshot of 262 students that presented with areas of concern. The highest one you can see is 76 students presented with anxiety. And then if you scroll all down, you can see depression, 68, and you can also see suicidal thoughts, 7. So from this snapshot, just from the top 2, from anxiety and depression, you can see that that's totaling 144 out of the 262 students that presented through term time last year. So this is obviously trending and increasing. So the fact that this was increasing, we had to address to see, other than the support within our team, what other additional support we could get. So this led and triggered us to carrying out research, and we have partnered with Elemental Social Prescribing. I had attended a conference where they had showcased their business and all what it does. And we met and had a demo, and to cut a long story short, we were the first college in Northern Ireland to partner with Elemental Social Prescribing platform. And it's a digital platform. And the local company Elemental is an award-winning company founded by two former community development workers, Jennifer Neff and Leanne Monk-Odsel. So I know, we are aware of what social prescribing is. It's a growing movement, but social prescribing enables health and social care professionals, community development workers, and others to be referred to a social prescribing link worker to avail of community support intervention. So we worked closely with Elemental to develop our platform to meet the needs of our students and our reasons for concern. Obviously, the stages of the social prescribing for our student, as we connect with our students, we then refer them onto our platform. They're engaged with community support interventions, and we then measure the impact. This gives you a sample snapshot of a student's journey. We can identify students to participate. For example, we have a team of progress coaches that perhaps their attendance is flagging red. They will target this group. Or a student can make a self-referral via our website. We then carry out an assessment, well-being assessment, just to establish the level of their well-being. We then find out the support that the student needs, and we co-create a package with the community support interventions. And then there's frequent follow-up calls, and obviously maybe midway between treatments, we would call again to maybe redo the wellbeing scale, should it be SWEMWebs, GAD-7, whatever one we have used at the start, so we can compare and measure impact. This is a snapshot of some of the readings that we will get. Obviously, we can see our anxiety levels and whether or not we use GAD-7 or SWEMWebs. And it gives us as a student team an opportunity to keep an eye and to see the impact that our interventions are having with the students. For us, this social prescribing partnership with Elemental is a lot more than social prescribing. It's a lot more than signposting, health coaching, and a director of service. It's so much more. There's a wide, diverse range. And it also gives us an opportunity as an educational provider to close any gaps in support that perhaps we're missing. The platform also facilitates more students accessing and engaging in services. It empowers our students to understand their health risks and to self-refer, enables us to measure the progress and impact on their mental health, and it enables a smooth referral pathway. From the platform, we can see the impact on the student, we can see their initial wellbeing scale, we can see it midway, and we can see it completion. We can also get data such as the number of services that people are referred to, the capacity for referrals, the gaps in provision, and the most common reasons for referrals. And then we can also build our own directory of support within our hub and connect organisations to our students. So for us, it has been a massive success in reducing the students' anxiety, and the fact that the students can refer from our website. Self-referrals are increasing, and over COVID, this was a massive benefit for us that our students could self-refer from the website. So that's a very short snapshot of our Elemental platform and the partnership and our journey so far.
Thank you so much, Vanina, also for sticking to the time. Thank you for sharing your slides. I will come back to the main presentation, although I would like now to actually open the floor, and considering that we have such the keynotes, and the four of you are presenting some of the solutions that were in place in the regions that you represent also today. I would like to open the floor and the panel discussion to everyone. I've gathered about 6 questions that I would like to use as an introduction. But of course, if anyone else wants, it really should be open. Please feel free to raise your hand and chip in and join the question question or the answering at any stage. I guess the group is so full of expertise, it would be a shame not to join in. Listening to all of you, to the keynotes and to the presenters of the solution panel, I was wondering maybe, and I will ask because I'll piggyback on Fenine, but it's something that Morten mentioned at the beginning. You said political awareness, or there was a lack of political awareness. Carla also mentioned the fact that blind eye was probably going to lead to a lot of problems in the upcoming years. Morten, you also addressed the same issue here. Fenine, you've mentioned the quantile, so obviously there's been an assessment of the level of deprivation, as you mentioned. So there was a political awareness. How did it translate into you having the role of addressing that? And for example, recommending the elemental social prescribing solution. When did that happen? How did it happen? Who did talk to whom?
Yes, so obviously we work very closely with our widening access and participation team, and we're very aware that the cohort of students that we have enrolled within the college do suffer multiple deprivation measures from the data we do receive. So it's up to us as a college to ensure that they're getting the full support in the wide range of areas, should it be financial, emotional, the wide range of brackets that falls under that. So because we are aware of the nature of the student we're dealing with, and we do have a student support team in-house, but over COVID and through the pandemic, the increase was, should we say, there was a lot more demand for the service. And because we were remote learning and we were working every day 8:30 to 5, we were concerned about some of the students who were perhaps logging on. We were very aware that students weren't all attending classes, and perhaps if they logged on at 6 o'clock, 7 o'clock and needed help, and we weren't online. So that was the initial trigger that we thought we need some sort of digital platform where they can self-refer. This notification comes through to all staff, and when we can immediately start actioning. So we would get alerts and notifications. So feedback from students who have self-referred, who we have maybe carried out wellbeing assessments from initial contact, midway through support interventions and post-support interventions, has been so positive. And the fact that they can self-refer from their mobile phone, because students never leave their phones out of their hand. And the fact that this is digital, it's a digital platform that they can access, has been really, really positive. But for us, it's recognizing the cohort and the nature of the group of students that we are dealing with. And that's what triggered the start of the journey and the partnership.
Oh, great. Thank you for that. That last comment of yours, that students never leave the phones out of the hand, that was the first question that popped up to my mind, and it is also something that was mentioned by Jenny, by Morten, by Carla. The increased, obviously during COVID now, the increased use of internet-based communication, and I'm calling it that out of a particular reason, because it's not just social media, right? It's also messengers. It's just a different way of communicating. It's twittering, then Instagramming. The type of communication is very different than verbal communication and face-to-face communication. Why? And so I'm addressing maybe specifically Carla and Morten. How did that also play a role, that the media used, the support used for communicating was so different from, or Jenny actually, sorry, obviously jump in as well. And so it goes to the keynote. Why was the choice of the support, or the choice, since it wasn't a choice, it was COVID, but that shift of using internet-based communication, messengers and short messages and so on, why could that have also played a role in having an impact on adolescent mental health? Is there a correlation, what I'm trying to say, is there a correlation between the the short format, the snaps, the maybe different tone that you would use in short messages, and how did that impact the younger people?
Morten?
Please
Can
go.
I address? Yeah.
Yes, please.
Well, this is hypothetical, but if you go to the sociology of Goffman with impression management theory, you make the impression management by creating a public self through limitation of the natural dialogue, and that can give some asymmetrical psychological contracts, and you get a very superficial communication between the person. So it's the art of limitation within genuine projections of yourself in the public. That has been a topic among some of our a bit older patients, 14, 15, 16 years old, talk about that. And some of the impression management model from Goffman may be something you can reflect on.
Sure, Carla, go ahead.
I think via messengers, everything, they have to communicate, and they weren't able to do that at schools. So they need some other platforms for it. And in puberty, it's all about who am I? And this who am I just arises through the mirroring of peers and with peers. You have to see how is everybody reacting on me? Is anybody laughing about my jokes? How do I look like when I'm with other people and everything? So one part of me says it's totally fine that they're using so much messengers, but on the other hand, I see the risk of it. So it's easier to do to be a victim of mobbing there, and of sexting and sexual offenders and everything. We had a lot about victims of that. What we need is like we call it the netiquette of digital communicating, and some rules about how do you present yourself and how you shouldn't do, because sometimes they're in big messenger groups, it's like a dynamic which becomes very destructive. Once we had a very special thing at one school in Germany where they were posting very bad racist stuff, and other students did that too, and it was getting more crucial racist, and it was so bad because they wanted to say I'm someone too, because they couldn't show that in school by playing soccer or anything else. They have to do it with these more badly posting. So who am I? But how can I be a good person in such digital communication? This challenges us. So this is just.
Morten, I also think that you appeal to a larger community when you go online, because our friends in Facebook and Instagram is not our friends in a more conventional way. So it's much more vulnerable than the usual day-to-day conversation in more symmetrical psychological contracts with your friends. And that also is a topic we need to address, but that is a pre-COVID problem, but maybe it has been fueled by isolation.
I would like also I'm really interesting, obviously, in the way that representing, or how do you name it, Carla? That since you are probably still defining your identity, that's why you need so much that mirroring, or that the understanding and the responses of the peers. And on the peers, I know that Mark has a lot to say, and I've also seen the question in the chat, Alexei, but this joins one of the last questions I would like to ask. So we'll come back to that just in a moment. Maybe opening and handing over also a little bit to Mark on the peer-to-peer, and also asking about self-regulation, and so also including Martin into that question. I have a 5-year-old, so I don't know too much about teens, but I know about regulation, emotional regulation problems. And maybe I was wondering, you all mentioned that routine was important because it was a protective factor. Obviously, COVID broke those routines, and especially not only the routines, as in I'm getting up to going to school, or I've got a certain day laid out outside or in front of me, but it also removed the possibilities, the opportunities for venting and for actually self-regulating in terms of exercising, sports. Carla, as you just mentioned, as being in the being at school in the playground and shouting at someone or pushing someone without getting excessively violent, but showing that we are someone as opposed to the peers, or we are better than the peers. So I was wondering that is it the regulation? Sorry, is it the lack of routine? Well, there's another one. Is it the lack of routine? Is it the lack of venting channels? And maybe Mark and Martin, maybe you can tell us, and Morten, you can tell us more about that lack of venting opportunities, and maybe that such projects as Mark described, that was very positive in building something and putting stuff or having a creativity process and doing something. What was your experience with that, talking to the teens?
Yeah, thanks, Alexia. I think that's a really interesting one, and I think it boils down to the issue of separating their real world experiences, or our awareness of the need to separate their real world experiences from their experiences online in a virtual space. Because if you look at what they're experiencing, it's a fragmentation. There's a fragmentation of self. So they might regulate themselves well with a family in a different way with their peers. But where do they go to that is there can be consistent level and form of self-regulation? They're caught between the different worlds. So I think our role as developer and the developer of solutions is to encourage them to be creative and critical about the technologies they're using, and for us to build that into the process of development. I mean, I'll mention wildlife briefly because that was designed to help support the mental health of young people in lower middle income countries, and that was a story-based project, a story of Molly whose parents go missing, and it plays out in virtual reality. Getting them involved in the development of that story based on the sorts of environments and characters they would want to be was an end in itself. You could see them referring back to themselves and getting a sense of being involved, participating, that you could see literally at the moment, over sort of 2 or 3 hours, the sort of difference in their sense of self-esteem. So again, I think it's, but we're able then to use that to develop the intervention further for people like them. But that, I think in terms of the process, I think we need to remind ourselves that actually by engaging them, that gives them a place to participate and to belong and to be and express themselves. And so sometimes I think let's just not always look at the product, what comes out at the other end, but how do we, through proper easy for me to say, proper co-creation rather than co-production, which I don't think is sincere. I think co-creation is possible, but that is an end in itself. And it creates a space where they can be and belong over time with other people like them. So it's about creating those spaces, those networks.
Martin, would you like to tell us from feedback that you've been receiving from the users of your app about maybe how it helped them vent or channel their emotions?
Yeah, sometimes we get feedback, not very often actually. But I think our experience is that we see that they use it in the evenings. They use it to, they build up a kind of stress the whole day, and they have a hard time to calm down in the evenings. So I hope our solution helps them at this point on the day. And yeah, and it also brings a kind of routine. I mean, we talked a lot about a routine which is necessary, and it brings a kind of routine in the evenings. We always tell, if we are in contact with users, we always say, try to find a time of a day in the mornings. I prefer the mornings for myself, for mental practice, but for children it's hard, I think. They usually do it in the evenings, so they have in the evenings the time for this part, this kind of routine for her day. And it's a good end of the day for them because they calm down and they get a good night's sleep. So it's a good tool, yeah.
Finine, from your students, I mean, obviously you are evaluating, as I suppose, their mental health and well-being through the use of I keep on looking at the name Elemental, sorry, of Elemental, of the solution. Have you received any feedback and like beyond obviously an improvement in their mental health and well-being?
Yes, we actually did hold a focus group with random selection of users to find out their opinions and views. And interestingly, one common feedback coming back was that students preferred to self-refer via the digital platform rather than come in face-to-face to meet with staff members who they would see around the college. The fact that the support was external from the college and we were just part of the process, this was a massive advantage for the students in the college, that the people they would see around the college, the staff, that they didn't have to come in to do that face-to-face.
Jenny, can you confirm that for Medified?
Yes, we have collected feedback, and during this co-creation process, the feedback has been very supportive, and as well as patients, as healthcare professionals have evaluated that this kind of solution would help to follow the development of mental health, because patients felt that it is easy to track their mood and change of it, and then patient can go to the appointment and the nurse can see from her or his platform, and you can communicate and discuss about that, and you don't have to only remember, because you can, as we all know, that you can forget what have happened, but when you can just put them up and then you can go for appointment and check those and discuss what has influenced that you have a bad mood today, or what make you feel better this last day or something like that. I think it's the feedback has been supportive.
I don't know if you've seen the question I addressed directly to you in the chat, which goes to the evaluation of Medified and to what extent it is actually affected by the state of depression of the young people using the app.
I'd refer it.
Alexei, if I'm misreading your question, please feel free to intervene, obviously.
I'm not sure, do I understand this correctly? Of course, it's when you track your mood, it's subjective feeling, and you can write down what you.
If I may, I believe that the question was going on seeing the particular type of users that Medified would bring along, whether the assessment of Medified itself might not be biased.
Yeah, that's quite true, but we are trying to now validate this with these low or moderate depression symptoms, because it was the purpose of this application which they have developed. But of course, there's always possibilities for biases, as we all know. When you gather subjective data and you are going to analyze with some kind of algorithm and so on. There is always possibilities for biases, but mainly, of course, if you write something down with the pen and paper, you can also do mistakes and so on. That it's quite ethical question what is actually subjective and how, when data is biases and so on.
Yeah, it is. It's a very tricky question. That's why I'll also raise Alexei's other question. As I said, I had it on my paper as well. Maybe as that to lift a misunderstanding. I don't think Martin was saying to pass it as a medical device, but as a medical application, which is maybe a very German process that has been launched last year here in Germany. So basically, doctors can prescribe apps. And interestingly enough, the medical apps, that's what they're called medical applications that can be prescribed by doctors. And as a patient, you can use them then for free. The cost of the app is then paid by the health insurance. That's fairly new, and it's a difficult process to be approved or certified as those medical apps, as Andy just put in the chat. Interestingly enough, the first two apps to have passed that certification process in Germany were actually depression apps, or like apps fighting depression. So which is probably why also Martin was mentioning it earlier, that it could be something he's considering in the future for Bodaboo. But my question also was, and I can't read my writing anymore. Maybe it was just asking Jenny or Mark if something like that was also happening in Finland or the UK, those medically prescribed apps, and if you had heard of that. It's unreadable.
Actually, we have in Finland a health technology assessment system, and they are evaluating several technological solutions, not only applications, but I know that our Social and Welfare Ministry has started to develop and discuss about same kind of model what you have in Germany, and I have been involved few discussions, and because Oulu Health is one of part, and we are maybe involved in future this kind of process that we are going to develop this kind of system also in Finland, that doctors, for example, can prescribe applications and so on. But it's a little bit challenging process because the evaluation of application will be difficult and challenging.
Yes, well, I guess Martin can tell a story about that, because it's quite a journey once you engage in that certification process.
Yeah. We never start with DIGA, which is the German process. I think there's a pre-step for prevention applications, which are also able to be kind of certified, which is a little easier and which is more the direction I would go with my app, because the DIGA process is just insane.
All right, well, Andy, I left you the whole of 3 minutes to wrap up, but before I even do that, I will share my screen again, because I meant to show you this slide and to announce that here in Cologne Bonn, we are co-hosting and we're supporting the Köln-Bonner Woche of Seelische Gesundheit. That was good German-English mix. That's happening every 2 years. It's always around the 10th of October, the International Day of Mental Health. And the idea, which is quite, which is why we support it, is bottom up, and there's everyone here from the region can suggest or can offer to show new forms of therapy, new approaches, like co-design ideas or projects, and introduce them to the public. This year it's taken place online, so whoever speaks German as well as Andy is more than welcome to come and join and listen to stakeholders here from the region. So I just wanted to mention this before I let you close.
Thanks for that. That's just lovely. I think one of the nice things about today's session, as someone who started working in mental health 30 years ago, is the excitement I get of seeing solutions and approaches to adolescent mental health that weren't around when I started at all. So that's fascinating from today. So thank you very much for all our speakers from the wide variety of our ecosystem, from Norway, from Finland, from Scotland, from Northern Ireland and Germany. It's just brilliant. The good thing about these sessions are, just so people are aware, these are recorded and we serve these up on our website, where we end up having more people watch them after the effect, because people are out doing different things during the day. And the one we know where there's the most impact is the one on mental health. So that's important to understand. I think today we've seen a great analysis of what both need and solutions are available. These thematic ecosystems, though, are permanent. They're obviously multi-stakeholder. And our next in the series we're going to be exploring is actually going to be in January, around the 20th of January. And the topic for that is going to be around substance misuse. We expect to hear again then from experts in the field from across our global ecosystem network around the whole gamut of the area around substance misuse and the use of illicits, legals, etc., and the impact that's had on people's mental health. Not necessarily to do with COVID, but the impact that's having in terms of service provision. And the last thing I'll leave you with is we've heard weekly now warnings of mental health tsunamis in the way that we used to around the tsunami of aging. And we have to be careful about the language we use, because people start to listen to this and see a negative connotation which wasn't there before. And I think we need to have a listen to what we've heard today and see some great solutions, some great ideas from those in Northern Ireland, across using Elemental to the brilliance in both Germany, in Norway and in Finland, and in the Highlands and Islands, to see there's some positivity here. So thank you very much for today, and thank you to Alexia in Rand and Bonn, and also with our Norwegian ecosystem, Sergio, as well. Thank you for today. Thanks for coming along.
Thanks, everyone.
Goodbye. Okay.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye bye.